Good evening. I have no financial disclosure. The outlines of my presentation will be as follows. We'll start with an introduction. We'll talk briefly about the classification nomenclature, and we'll follow with lymphatic malformation management, and we'll talk then about our experience. So orbital vascular lesions is a term that encompasses many different pathologies. In one study by Shields, they represented around 17% of all orbital tumors. There was in the past lack of proper nomenclature and classification for orbital tumor or vascular tumors, which led to some confusion between ophthalmologists and orbital surgeons alike. However, the International Society for the Study of Vascular Anomalies, they approved their latest or newest classification 2014, which was later updated in May 2018. Here's a table that was borrowed from Dr. Sundar article, which simplified this classification. They divided the classification into two parts: vasoproliferative lesions and vascular malformations. The vasoproliferative lesions are further divided into benign, which includes epithelial hemangioma, locally aggressive and malignant. And the vascular malformation can be simple, capillary lymphatic, venous, or arteriovenous, or can be combined. For example, lymphatic-venous malformation, and also can be associated with syndromes, as you all know. Some incorrect names that have been used in the past, I'll touch upon some of them. For example, infantile hemangioma was or used to be called strawberry hemangioma, capillary hemangioma. For lymphatic malformation, used to be called lymphangioma till this day. And cavernous venous malformation, sometimes it's called cavernous hemangioma. So for lymphatic malformation, it's a benign, congenital, and low-flow lesion. They account for about 4% of all orbital tumors. It's not that common and can be purely lymphatic or combined with venous malformation. So it's called mixed lymphatic-venous malformation. And they are further subclassified into macrocystic, microcystic, and mixed type. They can be evident at birth or present in the first few years of life, but sometimes the presentation is delayed till the first or even the second decade of life. They can be asymptomatic, cause visual loss, proptosis, extraocular muscle dysfunction, pain, and especially disfigurement. So unlike capillary hemangioma, they grow relentlessly without involution, and sometimes they show sudden enlargement after viral illness or hemorrhage. So their natural course is variable, and it's very difficult to predict. So go back here. Management of these lesions is a bit difficult, and in the past, the best or proper management was observation, unless there was a good indication to treat it. And the surgery was the gold standard of treatment, later on followed by the new or introduction of intralesional sclerosing agent, and now recently medical treatment. So surgical results were often disappointing or let's say suboptimal at best due to high recurrence rate, which reached up to 58%, and also the complication rate, which was high. So this led to the introduction of or the use of sclerosing agent. And as you can see here, we have several agents available: bleomycin, ethanol, sodium tetracetyl sulfate, doxycycline, and so on. And there's a recent review in the literature in 2016 of different sclerosing agent for low-flow vascular malformation of the head and neck, and they couldn't find a significantly superior sclerosing agent due to the lack of good data in the literature, or let's say low quality of available evidence. However, they concluded that absolute alcohol has significantly higher complication rate. Bleomycin was first used as an anti-tumor agent It inhibits DNA synthesis, but later was discovered that it has a sclerosing effect on the endothelial cells, and first used as a sclerosing agent in 1977 by Yora. A study done by Rishora, which was a prospective case series, showed that they looked at the outcome bleomycin orbital lymphatic malformation in 13 patients. Out of them, 12 had more than 60% reduction. Side effects were minimal and transient. There were no respiratory or systemic complications. Barma-Sivam also reported a retrospective case series where they included 16 cases of orbital lymphatic malformation that were treated with bleomycin. They reported a volume reduction of more than 80% in 75% of cases, and a reduction between 50% to 79% in the remaining patients. One patient had transient mydriasis post-procedure that completely resolved after 3 months. Another developed hemorrhage immediately after the surgery, orbital hemorrhage immediately after the surgery that required lateral cantectomy, drainage, and redo treatment. None of the patient developed skin pigmentation or pulmonary complication. So if you look at the literature, there is an issue with reproducibility of the results due to several factors: wide variation in agents, variation in dilution, variation in aspiration injection ratio, who should do this procedure, oculoplastic or interventional radiologist, should be do under fluoroscopic guidance or ultrasound, and how many injections is the limit. So the future aim is to standardize the procedure and to evaluate the results based on the new classification, and to solidify the evidence, if possible, by randomized clinical trials. So in KKISH, last year we did 5 cases of bleomycin treatment of bleomycin injection in the treatment of orbital lymphatic malformation, and we have 5 more under evaluation now. We do detailed clinical evaluation along with pre-treatment clinical photograph and visual field testing. For each patient, we do MRI, and sometimes we add CT scan. Duplex ultrasound is performed, and if there is a suspicion of high flow lesion, we do MRA. So the bleomycin comes in 15 units in 5 ml. We prepare to 3 units, which is 3 units per ml. We use the concentration between 1 and 3 units in the OR per ml, and it's done under GA. We do an aspiration injection ratio of 2 to 1. So if we aspirate 2 millimeter or 2 milliliter of fluid, we inject 1 milliliter of bleomycin. So this is an example of one patient who had previous surgery for excision of lymphatic malformation several years ago, and then he came with recurrence, and you can see it's an anterior lesion, and he presented because of the ptosis. Here's a photo showing the lesion intraoperatively, which was best approached through transconjunctival route. Here you can see that 10 millimeter syringe connected to a 3-way connector and a 1.5-inch needle. It's supposed to be a video, but it's not working here. I'm not sure. Anyhow, for the lack of time, I think I have to mention what's going on. So under ultrasound guidance, when we inserted the needle and we confirmed that we are inside the cyst by aspiration of blood, the bleomycin was connected through the other port and was injected in the predetermined ratio. After the injection, you can see that we are closing the wound because we use the transconjunctival rod to prevent spill of bleomycin into the ocular surface. And after that, you have to irrigate the ocular surface vigorously. And you can see his results after 1 month, and we've seen him almost 10 months after with no recurrence. Another patient, because of the lifetime, I have to skip it. She had a hemorrhage that persisted for 5 months in her hemorrhagic cyst that persisted. You can see here the MRI. This is her photo 1 month after the surgery. and we did an MRI 3 months after. You see the reduction in size, but the mother now chose to observe. So we did not repeat this procedure. So in conclusion, there is no agreed upon treatment for orbital lymphatic malformation. There is a need for standardization of treatment based on the new classification, and the evidence in the literature for sclerosing agent efficacy and safety for orbital lymphatic malformation is not strong yet, and further studies are needed. Thank you.